I'm an IADC, which is an international certified drug and alcohol counselor. I'm not sure how those letters fit together. And I am a little nervous, so you'll have to forgive me. I haven't done this in a long time. But probably 2 months ago, was it? I was asked to do this, maybe a month ago. I don't know, time flies. And actually, though, the beginning of the conversation probably started back in the 1940s, okay, when a guy named Jellinek started doing his infamous curve, all right? And what he was doing was looking for the common symptoms of addiction, okay? And that was probably the conversation, when the conversation started. Now, his whole studies were quite flawed, okay? But that's really where the conversation started. And here we are, like 80 years later, having a variation of the same conversation. What's the matter with that? Shouldn't have this been decided a long time ago? All right? I'm going to tell you straight up, straightforward, no questions asked, addiction is a disease. There is no debate. I'm not going to debate it here, okay? All right? In fact, according to the Center on Addiction, it is a complex disease of the brain and body that involves compulsive use of one or more substances despite serious health and social consequences. Addiction disrupts regions of the brain that are responsible for reward, motivation, learning, judgment, and memory. It damages body systems as well as families, relationships, schools, workplaces, and neighborhoods. Like diabetes, cancer, and heart disease, addiction is caused by environmental and biological factors. The consequences of untreated addiction often include other physical and mental health disorders that require medical attention. If left untreated over time, addiction becomes more severe and even disabling and life-threatening. So then the question becomes, though, is it a chronic condition? Because that's kind of what we're here for today. Is it a chronic condition? Well, according to the U.S. National Health Statistics, a chronic condition is a disease lasting at least 3 months. Often they don't have a cure, but you can live with them and manage their symptoms. So we're going to explore that for a minute. And right now, for the next little while, I'm just going to talk about alcohol. And the reason I'm going to do that is because, quite frankly, it's easier for me. Fair enough? Okay. So if I say alcoholism, please think addiction. If I say addiction, think alcohol. If I say using, think drinking, vice versa, that kind of stuff, okay? Because really there is no difference between one drug and another. You know, some people will say, well, it's just alcohol, right? Or weed, right? That's our famous one everybody's fighting over, right? I just had a survey on the phone. Do you think marijuana should be legal? My answer is, I don't care. Alcohol is legal, and it kills more people in the United States every year than all illegal drugs combined. Legalize it, don't legalize it. I don't care. She didn't like my answers because it didn't fit into her questions. Okay. All right. No drug is inherently good or evil. Okay? Really saying, you know, that marijuana is good and meth is evil is kind of like saying laundry detergent is good but bleach is evil. They're just chemicals. Okay? It all boils down to how fast. How fast do you become addicted? How fast do you go to jail? And how fast does it kill you? And that's really what it boils down to. Okay. The first thing we need to establish is, what is an alcoholic? or an addict, right? Just think back and forth. A lot of people will say alcoholics drink every day. Well, that's not necessarily true. Okay? Would it surprise you to know that a lot of people who do drink every day are not alcoholics, and a lot of alcoholics don't drink every day? Okay. Many people who drink every day do follow the low-risk guidelines. Okay. Now we got to figure out, leads us to the next thing, what are low-risk guidelines? Okay. Low-risk guidelines, I learned them from the American Medical Association when I was doing the 12-hour Iowa drinking driving courses, teaching the classes. But actually, that, to my knowledge, that's who established them first. Okay. So low-risk guidelines are 0 to 2, because 0 is the only no risk, right? So it's 0 to 2, but you have to space them an hour apart. Now I see we're all females in here, okay? So the guys must know everything already. I don't know. Okay. Ladies, we have to take one off because of being female. Okay? Or 0 to 3, if you drink 3 times a week or less, again, spacing them an hour apart, but you have to, can't exceed 14 in a week. Okay? And you can't save them all up for Friday night. All right. Now, these are standard drinks, folks. So now, it takes us to the next question. What is a standard drink? Well, a standard drink is about 12 ounces of roughly 5% beer, 5 ounces of approximately 12% alcohol wine, 1.5 ounces of 40 proof liquor, and 1 ounce of the higher, like 80 proof liquors. Okay? So those 24-ounce, 11% malted beverages that a lot of people are buying now are not single-serving containers, okay? But unfortunately, some folks just don't get it. You know, back, oh man, I've been doing this probably 20 years. Substance abuse counselor, not speaking like this. But, so probably about 20 years ago, one of the first clients I ever had, he came in, and the reason he came in for an evaluation is because he had gotten charged with OWI, or drunk driving. Is it DUI in Nebraska? I'm from Iowa. So he kept telling me, I only had 2 drinks. I only had 2 drinks. Well, his blood alcohol was in excess of 0.20. Okay? And I kept saying, no, that's not possible. And he kept saying, yes, I only had 2 drinks. And I kept saying, no. And we went on and on like this. All of a sudden, the light bulb goes off above my head. And I said, describe those 2 drinks to me. And he said, well, I went and I bought, 2 half-liters of soda and a pint of vodka. And I dumped out some of the soda out of each bottle, and I split that pint of vodka in those 2 bottles of pop. See, I had 2 drinks. Well, considering that vodka generally runs 80 proof and above, and there's 16 ounces in a pint, right? That's a whole heck of a lot closer to 16 drinks than 2. And quite frankly, that would fit his 0.20 blood alcohol level a whole lot better than 2 shots, right? Okay. So, truthfully, some people just don't get it. Now, the other argument that I get, I know what an alcoholic is. They can't quit. Well, that's really bad news for me because that's kind of my job. So if an addict can't quit, I might as well go dig ditches for a living, right? And it's even worse news for them, okay, because they're probably all going to die fairly young if they can't quit. And they're going to have kind of a crappy life until they do, for the most part. The National Institute on Alcohol Abuse and Alcoholism says that in 2015, approximately 88,000 people die annually from alcohol-related causes. So if they can't quit, that's a problem. You know, I said before that a lot of people, a lot of alcoholics don't drink every day. And it's always a red flag for me when a client comes in and says, well, I'm not an alcoholic. I don't have a problem. I only drink on weekends. And I'll say, well, that's good. I mean, that's okay. But why do you only drink on weekends? Well, I don't want to go to work with a hangover. And I'll say, okay, that makes sense to me, but why don't you go out on Tuesday, have a couple beers, and go to work on Wednesday without a hangover? And they're like, well, that's never going to happen, because when I drink, I drink. Now, that doesn't necessarily mean that they're addicted, because in that definition, then almost every college student would be an alcoholic on Thursdays. But the fact that they feel like they can't go out on Tuesday and have that one or two, that could indicate a problem. It's definitely a red flag when my clients are talking like that. Quitting, in fact, is the recommended treatment, right? That's how we treat addiction. The first thing is just quit. And my clients get so mad at me when, they'll say, well, my family says, why don't you just quit? I say, well, that's 100% accurate. And they'll say, well, it's not that simple. I said, yes, it is that simple. It's not that easy, but it is that simple. There's a difference between that simple and that easy. So addicts can quit. What they can't do is go out on Tuesday night, drink one or two, and then say, you know what, I've had enough, bring me a Pepsi. That's just never going to happen with an alcoholic. Okay? They are going to continue to use, once they start, they are going to continue to use until something stops them. They're going to get drunk enough, they're going to run out of drugs, run out of money, they're going to pass out, they're going to go to jail, maybe end up in the ER, but something is going to stop them. They're going to keep using until they have hit a certain point to where they can't use anymore. Some of my clients are pretty good. They can use for days. That's no joke. But they can't use just a little bit and then stop. And they can't do that. Now, a lot of alcoholics, they can force themselves to do that maybe once, okay, by kind of white knuckling through it, but they're not going to be able to do it comfortably, consistently over a period of time. Very quickly, they're going to be right back where they left off. And it really doesn't matter if they've been sober for a day, a year, 6 years, 60 years. If they are truly addicted, once they start using again, they're going to go right back to where they left off and possibly one step farther. Okay. So there is no cure for addiction, but it can be managed. Now, doesn't that kind of sound like a chronic condition? Okay. A chronic disease is a disease lasting 3 months at least. Check. Doesn't have a cure. Check. But you can live with the disease and manage its symptoms. So now hopefully we've established that it is a chronic disease. Fair enough? Any arguments? If you're going to argue, be quiet. Okay. Just kidding. If you want to argue, go ahead. I'll explain why you're wrong. We'll move on. That's what I always tell my clients. Okay. I think what's more important, though, than discussing the nuances of whether it's a disease, whether it's not a disease, all that kind of stuff, is what can we do about it? How can I help? To me, that's more important than even if it's a disease. Well, I think one thing we can do is we can reduce the stigma. You know, a lot of people would say, well, it's not a disease because it's self-inflicted. Well, I would argue that a lot of diseases are self-inflicted, at least to a degree. Okay? My doctor keeps trying to convince me that if I eat less things that actually taste good and start eating more green leafy things and maybe lose 100 pounds and exercise a little more, that my risk of heart disease would drastically drop. And I don't question that what she's telling me is true, but up to this point, I have chosen not to do that. But, you know, heaven forbid, knock on wood, if I were to have a heart attack and be in the hospital, my friends and family would send me cards, they'd come visit me, probably send flowers. They wouldn't say, well, you fat pig, you got what you deserve because of the choices you made. Well, a couple of my sisters might, but that's beside the point. You've never met my sisters, you're lucky. Okay. I'm sorry, I can't help it. Go ahead. I get a little off center sometimes. This stigma is so pervasive. You know, I work at the psych unit at Jenny. I don't know if you knew that or not. And almost never, and I've worked in residential programs, okay, almost never do any of my clients ever get a card, flowers, nothing. A lot of them in the hospital don't even get visitors. Isn't that sad? They're as sick as a person on, floor 2? I don't know the hospital very well. They're just as ill. And part of the problem is things that they have done. And I'm not going to excuse it, okay? But it still is kind of sad. Years ago, I'll tell you how pervasive it is. Years ago, when I was working up Northeast Iowa, we had a psychiatrist there, and she would not see any of my clients, any of them, with her door open, or with her door closed, I'm sorry, because my clients were criminals. Technically, she was probably right, most of them, but there is a big difference between criminal behavior and a dangerous person. Okay, most of them, by the sheer act of buying their drug, had committed a crime, but they weren't dangerous. Most of them, I have never, maybe once, felt threatened or uneasy with a client in my office. Okay. And in group of clients, I worked at a correctional facility. I was the safest person in the room, okay, because I was there to help them, and they knew that. Okay. People in my family said, "Oh, you're going to go work with those people?" I said, "Oh, nurses aren't that bad." Okay. All right. So what can we do? Maybe we can reduce the stigma. Oh, I'm probably falling behind here. Okay, I'm all right. But also, maybe we can take a little introspection. If we have a client or a patient, however you want to refer to them, do we treat them differently? Do we look at them differently? Okay. Is somehow, they're just a meth addict. They're not going to get better. There's no point in putting a lot of effort into it. Are they somehow less deserving of our attention and our help than little Susie Homemaker over here? Now, I'm not saying that anybody in this room falls into that category, but I know people that do. They're just like, well, it's just meth. They're just meth addict. They're just going to leave here and go back out and use again. which a lot of cases, unfortunately, is accurate, but we still need to try. There's no point in doing an eval on them. It's not going to work. How do we know that? We never know when it's going to get better, right? Okay. So you all get an A+ today because you're all here, and I'm assuming you're all here to gain a little information, a little knowledge. We'll pretend you're not going to get CEUs for being here, okay? Because that's the only reason I go to trainings is CEUs. But so you all get an A for today because you're here to learn and you're here to get more understanding. So, but what we need to do is we need to start a conversation with these people. Okay? We have a tendency to not want to talk to them, not want to ask them questions. Okay? So when you start that conversation, I want you to understand, don't believe everything you hear that comes out of an addict's mouth. All right? Because it scares me sometimes when even professionals, they believe it. And I'm like, look at this person. This person doesn't use meth once a month. My clients are very good at saying, I haven't used except when you can prove I used. Does that make sense? They're very good at that. Okay. Now, don't get me wrong. I like most addicts. I do. I chose to work with them as a profession. I like working with them. I like them. Most of them. I'll just leave it at that. But I got news for you people. Addicts lie. There is no question. Addicts lie. And addiction takes perfectly wonderful, decent, honest people and turns them into liars because you have to lie for the addiction to survive. And the number one person they lie to best is themselves. They're such good liars that they believe what they're saying is true most of the time. They will minimize amounts. They will flat out deny using. They will say, oh, I said, but you don't use, you were positive coming in to the hospital. Oh, well, I used that one time, but I've never used before that. God, we're good to catch you on that one time, you know. DHS catches you on the one time you used, right? Talented people. Okay. But the more we know, the more we can point out their errors in their thinking. Now, we're not going to condemn. We're not going to lecture. We're not going to criticize or judge. But we can point out that a pint of vodka split between two bottles of pop is not 2 drinks. Do you understand this is 16 drinks? This is not 2. Okay? Those are the kinds of things. And we need to know these kinds of things. When you go to the bar, and I'm sure nobody in here does, but when you go to the bar, do you know your bartender really, generally, overpours? Because they want tips, right? So you're sitting here thinking you had 3 drinks, but if he overpoured by half an ounce each time, you very well may have had 4 or 5 drinks. We need to understand those things because 2 drinks here, the difference between 2 drinks and 3 drinks or 4 drinks can be the difference between going home and going to jail. Right? It can be literally that close. I see a lot of small females in here. You can literally, 1 drink can put you over the edge. We personally need to know these things. A 10-ounce glass, half full of vodka, is not 1 drink. But my clients, a lot of times, just don't get it. So what do? We need to ask questions. We need to start the conversation. Even if we don't believe that anything's going to change on that day. If they're drinking a pint of vodka a day, we need to make sure they understand that 16 drinks. That may not stop them from drinking a pint of vodka, but it gets the wheels turning in their head. Okay? We need to educate them. What is a drink? Why do you only drink on weekends? How come? Do you know that hallmark symptom of addiction? Once I start, I can't stop. Now, it may not stop or change how they're drinking, but it can get the wheels turning. And truthfully, clients have come up weeks or months later and said, you know what, Kim? I lied before when we talked. I'll be like, no. And they'll be like, yeah, but you know what you said got me thinking. And I just wanted you to know that I drink a lot more, I use a lot more than what I told you. Construction all over the place, huh? That's all right. Okay. You know, back when I was working at a correctional facility, I had a client say to me, it's your job to make me quit. And I said, holy crap, then I'm going to resign. Okay, because your DARE officer couldn't make you quit, your teachers couldn't make you quit, your probation officers couldn't make you quit, your mama couldn't make you quit. What makes you think I'm going to quit, make you quit? My job is to make you think. And he said, well, I think you're a... And I said, then I've done my job. Okay. And that's a true story, but he was joking. It was all in fun. All right? So don't expect to make them quit, that somehow on that particular day you're going to influence them. Okay. But plant the seed. Now, okay, folks, what if they're on meds? Okay. Can we educate? Now, I'm really not, I feel that educating my clients too much about the interaction between their drugs and their medications is kind of outside my scope of practice. So I refer them to the doctor or to the nurse or to the pharmacist. Okay? But maybe I do feel that I'm qualified to try and convince them that if they're taking 2 milligrams of Ativan, 2 oxycodone, and drinking a fifth of vodka, that may possibly be a recipe for disaster for them. Can we, because you will be surprised how many people don't get that. They just don't understand that. Alcohol often has harmful interactions with prescription medications, over-the-counter drugs, and even herbal remedies. And we have a tendency to think, oh, it's sold over-the-counter, it's herbal, it's natural. Yeah, not so much, people. They can interact with those. Alcohol interacts with medications. Interaction with medications may cause problems such as nausea and vomiting, headaches, drowsiness, dizziness, fainting, changes in blood pressure, abnormal behavior, loss of coordination, and accidents. Mixing alcohol and medications may increase the risk of complications such as liver damage, heart problems, internal bleeding, impaired breathing, and depression. In some cases, alcohol interaction decreases the effectiveness of medication and may render it totally useless. Well, you're on medication for a reason, right? I mean, I hope no doctors are prescribing meds for no reason. If it's rendering it totally useless, what does that say about the condition that you're taking the meds for? Okay. In other cases, alcohol interactions may make drugs harmful or even toxic to the body. Even in small amounts, alcohol may intensify medication side effects such as sleepiness, drowsiness, and lightheadedness. And I know medications come with warning labels, right? But usually they're like this big. And really, who reads those? I don't. Of course, I don't drink. But my clients don't read those. I guarantee it. Or if they do read it, they'll be like, oh, that sounds like fun. Okay, that's true. I'm sorry. But, and the real scary one is this one. Let's self-medicate with alcohol. Folks, trying to self-medicate depression with alcohol is kind of like trying to put a bonfire out with a can of gasoline. It just doesn't work well, and it's probably not going to end well. Yeah. I have had clients who have never been suicidal except when they were intoxicated. 25%, and my opinion is, because I've heard different numbers, but I went with this one because this is the one that I could cite. Okay. 25% of U.S. suicide victims are legally drunk when they commit suicide. But that's still a quarter of all suicides. And 40% of treatment-seeking alcoholics report attempting suicide at some point. But why? Why? Well, alcohol is a depressant. But you knew that. So if I'm depressed and I dump gallons of depressant on top of it, there's only really one way for that to go, right? It's going to go down. It creates more and more depression. Plus, substance abuse leads to destructive behaviors. Remember, addicts lie. And the people they lie to the most is family and friends, which creates guilt and sadness. Addicts spend money that they can't afford to spend on things they shouldn't be buying in the first place. Addicts have affairs and sexual encounters that they regret later. They lose jobs. They lose homes. Some of them lose custody of their children. And all of these increase the feelings of guilt, lower self-worth, increase a sense of hopelessness, and death thoughts. So not only does the drug itself, like alcohol being a depressant, help increase it, but then the pile of manure they pile behind them as they go through also creates nothing but a depressed lifestyle, and they get thinking, well, maybe I'd be better off dead, or maybe my family would be better off without me. And truthfully, addicts do drive family and friends away. Family and friends get tired of the lies. They get tired sometimes of the stealing. They get tired of the patient or the addict's irresponsibility. Oh, I promise I'm going to do this. It never happens. I promise I'm going to quit. All of the broken promises. But mostly what family and friends get tired of is watching someone they love slowly kill themselves and destroy their lives in the process. You know how hard that is? To watch someone you really care about kill themselves? It's painful. And you can't blame the family for saying, you know what, I'm done. Now sometimes when the addict gets clean and they can really show that they're trying, the families will come back, and that's quite frankly, that's good when that happens. But a lot of my clients, they have no one except their using buddies. That's the only people in their lives. And when they quit using, their using buddies disappear like cockroaches when you flip the light switch on. Because using buddies are called using buddies for a reason. Once you have nothing more for them to use, you're not going to give them a ride. You're not going to give them any money. You're not going to let them sleep on your couch. You don't have a place for them to stay. They disappear. Now, when we were out using, we were using people too. We used them. So I'm not pointing any fingers at them. But they're not going to help you get clean. And again, let's not forget the accidental suicides, the accidental overdoses. and the I want your attention, but dang, it went too far. Okay. So what do? Just ask. But you need to ask directly, you need to ask honestly, you need to ask straightforwardly. Is that a word, straightforwardly? Okay. Don't beat around the bush. Don't, I don't know what's the word, pussyfoot around. Just ask. Just ask. So, we've got to have somebody to blame, don't we, in our society today? We've got to have somebody to blame. Well, who can we blame? Nobody. Can't blame the addicts. Can't blame the family. We can't blame the doctors. Well, I kind of like to blame the doctors. I'm sorry. But, oh, I'm just kidding. We can't blame anybody. Or maybe we can blame everybody. I don't know. I got a question though. Does your doctor ask you if you have a problem? If they do, it's probably on a form or a piece of paper. Unless you got a really good doctor, which maybe you can give me their number later. But, you know, you go in and it's on this little form checkbox. But you know what? Isn't it easy to lie to a piece of paper? Right? It's easy to lie. It's much harder to lie to someone when it's face to face. I am 59 years old. And in my lifetime, I've been pretty good about going to a doctor's when I'm supposed to. And, you know, sometimes doctors retire or I moved or that kind of stuff. So I've had multiple doctors in my lifetime. And in all those years, true story, in all those years, only one doctor that I've gone to has ever even broached the subject. And I find that kind of fascinating and kind of sad and kind of scary. You know, I never thought about it for years until just recently. And I got to tell you that the doctor who did broach the subject, I was in there, I had that kind of creeping crud that went around everybody all winter long. And so I went in and, you know, we were just kind of talking how you do with the doctor in there. She's like, oh, where do you work? I work at Jenny. And by the way, this wasn't a Methodist doctor, so I'm not. But I work at Jenny. She goes, oh, what do you do there? And I said, I'm a substance abuse counselor. And her whole demeanor changed. And it changed noticeably. And she was like, oh, well, how long have you been doing that? I said, I don't know, 20 years, give or take. Well, she had been talking about prescribing cough medicine with codeine. And her demeanor changes, and she looks at me, and she goes, do you have a history? And I looked at her, and I thought, oh, we're going to play now. I said, doesn't everyone have a history? And she just looks at me, and she just blinks, because she didn't really know what to say. And she goes, well, you know, using some medications can trigger, and she just left that word trigger hanging out there. And so I looked at her and I went, trigger what? And she just looked at me and she just blinked. So I left this very long, very uncomfortable pause, just looking at her while she looked at me like I was so confused. Finally, couldn't take it anymore. And I said, oh, you want to know if I have an addiction? Because, of course, she had assumed that because I was a substance abuse counselor. And I said, well, not to opiates. Well, she wrote the prescription. I filled it, didn't take it, and she's not my doctor anymore. Because you know what, my thing is, I'm a substance abuse counselor, for God's sakes. I've been doing this for 20 years. How sensitive could I possibly be to that question? You know how many times I've been asked that question? Oh, are you in recovery? Right? It's a very common question. And my answer is, I have not been higher drunk since 1988, okay? You can take it for what you want after that. But if this doctor couldn't ask me this directly, straightforward, and honestly, what makes me think that she's going to be able to ask any of her other patients who are going to lie to her besides? Possibly. So, yeah, I got a different doctor. I got fingers crossed. All right. So just ask. Ask face to face. Ask directly. Ask specifically. Ask honestly. I got to figure out, how much time do I got? Oh, I'm good. Okay. But watch out for vague answers. Because that whole statement of, I don't use anymore, can be completed by, I don't use any less either. Right? We have to watch out for those. Watch out for not very often. How often do you drink? Not very often. I pretty much guarantee that their definition of not very often is going to be different from your definition of not very often. I don't drink very much. Again, define very much. I love this one personally. I only use socially, which the true definition of social using, remember back when we were talking about low-risk choices? That is the true definition of social using. I use socially for my clients most often means I get drunk in public. Okay. Truthfully, most addicts, they could run for office because they can avoid answering questions better than any politician. Okay. They are good at it, and you have to pin them down. Do you take drugs? I don't do illegal drugs. Well, that's not really the question I asked, is it? Because there's a lot of drugs out there that are not illegal. So, do you take legal drugs in an illegal manner? And they'll be like, what? Folks, it's not that complicated when you ask directly. If I were asking these questions, and quite frankly I do pretty much every day of my life, I would say, do you drink alcohol? Well, not very much. I mean, it's not a problem. Well, that's okay. I just need to get roughly how often and how much. Well, I don't know. Well, okay. Is it closer to once a day, 2 or 3 times a week, once a month? What are we talking here? Well, yeah, probably at least 2 or 3 times a week. Okay, so when you say at least 2 or 3 times a week, are we talking that maybe it's closer to 3 or 4 times a week? Yeah, probably 3 or 4 times a week. Okay. So you drink maybe 3 or 4 times a week. And so when you drink, about how much do you drink? Well, not that much. I don't know. I mean, I really don't measure it, which is true. They don't. Okay. I just pour it out of a bottle, you know. Okay, that's all right. I understand that. So tell me, what does the bottle look like? And they'll be like, well, you know, it's kind of, you know, but I'll say, so sounds like a fifth, or does it have a handle? Well, no, it's not that much, 750 milliliter. Well, wouldn't that have been easier to tell me that like 3 sentences ago? Oh, okay. So you drink a 750 milliliter. That's fine. How often do you buy a bottle? Well, I don't know, maybe 2 or 3 times a week. Okay, so let me get this straight. I want to be accurate. So you drink 3 to 4 times a week, and you drink 2 to 3 bottles per week of vodka. Yeah, that'd be pretty close. Let's do the math, folks. Figure 3 bottles, because if they say 2 or 3, it's 3. Okay. That's around 75 drinks, because we're talking vodka. That comes to roughly around 20 drinks per drinking episode. Anybody think that could be a problem? If you don't think that's possibly a problem, give me a call tomorrow. I could maybe find someone you could get an appointment with. Okay. And remember, folks, that's what they're admitting to. It could be the truth, or it could possibly be significantly higher than that. So now you have the conversation started. Now what do we do? Let's say a client comes in because maybe a while back you had said something to them, and maybe you got those wheels turning, and they come in and they say, you know what, I've been thinking about it, and I tried to quit, and I can't quit, and I think maybe I have a problem, and maybe I need some help. The first thing we need to look at, people, is how hard are they going to detox? The ones we worry about most at the hospital are alcohol, benzodiazepines, and opiates. These can be very hard, very painful detoxes. Alcohol detox is dangerous. People die from alcohol detox. I'm going to make that perfectly clear. A person should never detox from alcohol at home without a doctor's care. It can cause anxiety, convulsions, shakiness, delirium tremens, hallucinations, heart failure, insomnia, nausea, and seizures. It is very dangerous and extremely uncomfortable. Opiate detox causes abdominal pain, anxiety, sneezing, sniffing, body pain, chills, sweating, vomiting, diarrhea, insomnia, weakness, irritability, and nausea. It is dangerous and incredibly painful. Benzodiazepine detox, sleep disturbance, irritability, increased tension and anxiety, panic attacks, hand tremors, sweating, difficulty concentrating, dry retching and nausea, palpitations, muscular pain, possibly a little less dangerous, but it certainly isn't fun. Now when these people, now remember there is another side to this, not only is it physically dangerous, but when it is extremely uncomfortable, they are much more likely to say, screw this, I'm going to use. Okay. Which makes it more likely they're going to continue, and it's going to be around and around we go. So refer them, if you're worried about withdrawal, refer them to their doctor. If they are in withdrawal, please send them to the ER. It is a medical condition. Please err on the side of caution with detox. I mean, if they came in and said, I'm having chest pains, are you going to go, oh, I don't think it's that big a deal? Okay. Then, if detox is no longer a concern, okay, encourage them to get an evaluation. There are lots of places in Omaha and Council Bluffs where a person can be evaluated. I didn't bring a list of them because I was afraid I would leave some off and somebody get mad at me, and because it kind of changes all the time. But if you do need a list, you can get hold of me at Jenny. Just get hold of the psych unit. I don't remember my personal phone number. I'm terrible. But get hold of the psych unit and ask for Kim. I can give you some places where people can get evaluated. Okay. Tell them to call. Make them call. And call when you're standing there watching them, but please make them have the responsibility for making that phone call. And tell them to ask for a substance abuse evaluation or a chemical dependency evaluation. There is no difference. They're the same things. So they go and they get an evaluation. Sometimes they want to know what's going to happen. So I get an eval, what's going to happen? Well, there are multiple levels of care. The three most common ones in this area that are used the most and referred to the most are residential. Residential is your typical 28-day, 30-day program, 24/7, sleep there, eat there, everything there. Usually, like I said, 28 days, 30 days. Intensive outpatient is the next step down. That's 9-10 hours a week minimum. Could be more than that. Usually that's done with 3-hour groups or 4 2-hour groups plus an individual appointment each week. Usually intensive outpatient lasts 4 to 8 weeks, maybe 6 would be a good average. Next step down is extended outpatient treatment. That's a minimum, usually, well, I guess a bare minimum would be 1 individual session a month, but usually extended outpatient will start out at 1 individual per week plus maybe 1 or 2 groups per week. And kind of gradually, it should kind of gradually taper off in time. Now, best practice says that no matter where the person starts in treatment, whether it's residential, IOP, or extended, they should be involved in the treatment process a minimum of 9 months. The biggest mistake clients make, they go to a 30-day program, they get out and they do nothing. So they go from 24/7 counseling to 0. That's a bad idea. So then they go back to a residential program when they relapse, and then they do nothing, and then they go back and then they do nothing. And then they say, well, treatment doesn't work. Ideally, they would start out at residential, they would go down, step down to IOP, then do extended outpatient with gradually lessening and lessening. And as their treatment experience goes down, hopefully their social support, sober social support network will go up. So it should go like this. Okay? And I tell clients, you're going to be involved for 9 months. Plan on it. All right, so recap. Addiction is a chronic disease. Please, people, just start the conversation, whether it's clients, patients, loved ones, friends. Start the conversation. Don't criticize, don't judge, don't lecture. Just start the conversation. Be direct, be specific. Don't let the wool get pulled over your eyes. Remember, detox is a medical condition and can be very dangerous. And encourage the person to get help. All right, we don't have a lot of time. Any quick questions? Awesome. I always hate that person when I'm in a training and goes, so that'll keep you from all you from asking. Okay, thank you very much.